So I want to focus on transplant-related questions. And how many of the iptacopan study were post-transplant recurrent disease? You mentioned there was some transplant patients. In the papers.
There was 13 in the phase 2, was it?
Yeah, I'm thinking roughly 13, but maybe someone.
Sure.
12.
Okay.
We were close.
So I have like a mechanistic question. We monitor the complement factors, okay, and the nephritic factors. There was an excellent talk. So if you have a detectable nephritic C3 and C5 nephritic factor, do you have a preference? Iptacopan versus pegcetacoplan. And I pronounced it much better than Dr.
Well, the PEG people know I mispronounced it for a year and a half, so it's okay. I don't have a preference yet because I don't know enough about it yet. The issue, and we can even say, there are still people in the world that are not 100% convinced that the nephritic factors are disease causing. So
that probably can bring me to another question.
Yes, but the point is I don't think we have enough data just yet. The critical aspect is they're both AP blockers, and so if you put me in a corner and say, can I have an AP blocker or a terminal pathway blocker, I know what my answer is.
Yeah, sure. But at what level? I mean, it seemed like factor B is slightly higher than the C3 convertase, but I don't know. I really don't know the answer.
That you just said is an artifact of how we're drawing it.
Yeah,
so
probably because it goes back again.
Yeah,
to the
exactly.
C3
that is one big circular loop.
Yeah, I know. But so I really don't know what about C5 nephritic factor. This is, I mean, the common part we see is C3. I had a patient even with C4 nephritic factor.
Well, theoretically, well, speaking specifically about C4 nephritic factor, ultimately with the C3b that's generated by that convertase, that will then kick off the alternative pathway. So I would say that iptacopan by inhibiting factor B will ultimately benefit patients with C4 nephritic factor as well. And in fact, the studies suggest that in patients with C4 nephritic factor, even though it's the classical convertase that's created, their C4 levels are normal. So that side of the complement system is only a triggering event leading to the alternative pathway being massively activated. So I would say that C5 and C4 nephritic factor, we don't yet know if there's a clear choice of agent in that situation either. I don't know if you'd agree.
Yeah, there was some older data, and some of it might have been from us even, that said that if you had a C5 nephritic factor, you had a much more active terminal pathway, and that might be the group of patients that might benefit a little bit better from terminal pathway blockade. But it turns out that's not true. So even we don't agree with it anymore. So
if somebody has no proteinuria and has recurrent disease after the transplant, is he a candidate for any of these medications and stable kidney function?
We actually have cases coming up that actually address exactly that. And we have a transplant case. But I want to bring it up in the context of a real world case because they're all actual cases from our practice. Yes, go ahead.
Thank you for a great presentation again. What about the patients with normal C3 levels? So these studies included only the patients with the low C3 levels.
yeah, so I'll offer an anecdote, an N of one, but I have a patient with a C3 gene mutation who's lost native kidney, one transplant, on her second transplant, losing it after 5 years of eculizumab. She has a completely normal C3 level, but she's heterozygous for a gene mutation that makes half of that C3 not work. So a normal C3 level, this is an unusual anecdote, obviously, but a normal C3 level doesn't mean that your patient's not going to get recurrent C3G, if you will.
So the pegcetacoplan did include people with low normal C3 levels. The iptacopan didn't. The iptacopan was, I think the idea there was to come up with the purest population in the first ever study. You wanted people with complement turnover and just C3G. So it was done with the rationale that you were going to get a pure population. But as Carla said, your C3 level is dependent on how much you make as well as how much you turn over, and it can just be local. So we would not wish to discriminate on how you would treat based on your C3 level. If you've got a C3 in the biopsy, you're depositing it. Therefore, we would not wish to suggest that you shouldn't use iptacopan if the C3 level is normal. It was just an artifact of the way the study was designed to get the purest population, so that you were treating what you thought you were treating.
Thanks. So my question is, like, any of these trials, any of the 2 trials, going back to the transplant, do you know how long after transplant this treatment was administered? So it's just a little bit preparing the case as well.
I don't know I only know my own patients. I don't know the trial in general. For instance, was the median time post-transplant 1.2 years? I don't know the answer to that.
Just because if you think about the Mayo data, it's like coming back pretty fast. So if you administered the drug like a year later after it's recurrent, maybe that's set up for failure because it's already, there is a lot of IFTA in the kidney.
I wouldn't rule it out. And I'll just say again, because in 2019, when we first opened the trial, we entered mostly transplant patients, but there had been nothing before that. So the first 2 I entered were greater than a year since their diagnosis before they came into the trial. So I wouldn't rule out that late could be potentially useful for your patient, but again, don't wait. Yeah. Now that we can.
So just like last follow-up question. So if you are planning to do purely transplant trial, would you planning to do it early and just wait, because you dilute the effect, right? If you go too late, you might have a false negative results and we are all screwed up, right? And nobody going to approve it. So if there is any trial, should we try it early?
2 points. First of all, in the iptacopan trial, they didn't actually have proteinuria was not an endpoint, so they were relatively early. Coming back to when you should treat, at the moment we can't predict who's going to relapse, so we can't give it preemptively. There are 2 schools of thought. Do you do a protocol biopsy, and then if you see a glomerulonephritis, treat immediately, or do you wait till you see some evidence? These are groups of patients that we're going to have time to see a glomerulonephritis develop. It's not like atypical HUS where you can lose your kidney in a matter of days if you don't treat. So I think there is time in this group to watch and see if they develop disease, because they don't all. And then if you're seeing any evidence, you're going to biopsy. And then I would very much be of the argument that if you're seeing C3 deposition with a glomerulonephritis, you don't wait, you treat. You don't need to wait till the protein gets up. But I wouldn't give it preemptively.
So just challenging this a little bit. So if I have a patient who lost 2 kidney grafts from recurrent disease, I know that's going to come back. I don't need anything.
Well, you presume it's going to come back, and
I know that it's going to come back.
No, you presume it's going to come back, and I would agree with you generally. And I think there will be cases you're not going to want to do that. However, we cannot predict in an individual patient basis when we transplant them the first time, because if you do that, you will have patients dying of meningococcal sepsis that didn't relapse.
Alison. We'll probably take this as one last question before we maybe take a break or go to cases. We can look at the time. Absolutely.
Thank you for the great talks. Can I ask, is the remission criteria going to be defined for C3G soon? And the second question is, adolescents seems to be responding better than the adults. Is there a reason for that? Thank you.
Well, I'll speak very quickly. It'll be nice to see the iptacopan adolescent group too, to see if that is really true that adolescents are responding. I also have this worry that there's the second trial phenomenon. The first trial enrolled a group that had anyway. No concern. Back to your question about remission. Do you mean like, are we talking about, in the old days, we used to say a complete remission was something 0.5 or less, or is that what you mean?
So it's like in most pediatric diseases, nephrotic syndrome, lupus
Yeah.
nephritis, they have a remission criteria, but it doesn't happen in like aging. So is there like something that's going to be defined just back to the person?
Yeah, for me, this one's going to be tough to declare that because this is much more likely to be a chronic kidney disease patient group, which means scarring is going to be present, which means there's going to be some proteinuria related to the scar. So getting to the remission for me would be a normal albumin, normal blood pressure, so there's a whole lot of things that would be remission for me, but I'll let the group talk.
Well, for me, the question becomes, you're going to have two options, and you get it's straightforward. If the proteinuria gets worse, they're not responding. If they go to nothing, they've responded. And then we're going to be in the situation with the vast majority of them where we see a reduction. And then the question is going to be, should I switch to another agent to see if I can get that 1.7 grams down to less than a gram? And the answer is we don't know. Where do we draw that cutoff? And I think it's very difficult to answer that. I think some of this comes down to, is one better than the other? The trials don't tell us that. But in the real world, we'll start to see that, because we all have our individual points where we will want to try another agent. And I think where that is, I don't think any of us can answer at the moment. But essentially, that is your question. If it improves, how much does it need to improve before I try something else? And we don't know.
Thank you, David. So we are actually in really good time. We have 4 cases. They're all, like I said, cases from our practice. These are patients who've just been started on some newer agents, and we're really interested in sharing these and getting your insights. Do you guys want to take a 5-minute break, get some coffee, dessert, go to the restroom, and come back? All right, we'll take a 5-minute break. I love it. Amazing. Exactly what we wanted to get across.
Good.
Like 3/4, 1/4 way down.
Would you care for some coffee?
Sure.
This coffee is very hot.
Just want to say hi to Brian. Yes. Nice to meet you. I wrote to you a few times for the trial, and thank you for having us. I still didn't get a chance, but it was a good start.
Okay, well, good.
Thank you.
Yes.
Where's your bag? Yes, your bag. I don't need your bag anymore. I want to take a photo with you. I want to take a photo with you at the bag.
Yeah.
Yes.
Yes.
Oh, that's very cool. No, I was like, where's your vision? So I have to take a photo. All right. Oh, thank you.
How are you guys?
How are you? Oh, you have actually gone to Thank you so much. I think we should go ahead and get started. Yeah. We're going to go ahead and get started with our cases. If you can all please take your seats. So at this time, I want to invite our panelists here. You've already met Dr. Nestor, Dr. Dixon. I want to introduce Dr. David Kavanagh. He's a professor and director of complement therapeutics at the National Renal Complement Therapeutics Center. He is the chief investigator on several clinical trials of novel complement therapeutics in C3G and AHAS. And he and I co-chair, I don't know why it's written here, co-chair the Clinch and Complement Disease Gene Curation Expert Panel. David has focused on the genetics of complement system in the eye, looking at age-related macular degeneration, and basically finding the causative role of factor I haploinsufficiency in disease pathogenesis. He runs the GN and the vasculitis clinic at Freeman Hospital, and I have special affinity for him because he trained in the same lab that I did many, many years ago. So welcome, David. Really a pleasure to have you here. Our next panel, Dr. Sperati is an associate professor of medicine in the Division of Nephrology at Johns Hopkins University School of Medicine. He directs the Glomerular Disease Fellowship at Hopkins and has a particular clinical interest in complement-mediated kidney disease. He serves as a PI for multiple clinical trials and serves on numerous committees, including the ASN Kidney Health Guidance Steering Committee. Welcome, John. And our last panelist for today is Dr. Molnar. Miklos. So Dr. Molnar is a professor of medicine and the medical director of the kidney and pancreas transplantation programs and living donor transplant program at the University of Utah in Salt Lake City. His primary clinical interests include all aspects of kidney transplantation, has given talks at national and international meetings, and is the co-author of more than 300 articles in the field of nephrology and transplant medicine. So welcome all of you. And with that, we're going to go ahead and get started with our first case for today. So this is a 26-year-old patient who was evaluated for a kidney transplant back in 2020. This patient had presented initially in 2012 with bilateral lower extremity edema after he had a urinary tract infection. He was found to have proteinuria at the time, 0.7 grams per gram, underwent a biopsy which revealed an MPGN pattern of injury. At that time, several years ago, he was treated with supportive care, mycophenolate, and eculizumab, but despite that, started dialysis 7 years after his initial presentation in 2019. When he came for a pre-transplant evaluation in 2020, he was found to have a C5 nephritic factor. His C3 was low at 30. He had a low C5 and an elevated C5b through 9. He received a living kidney from his mother in May of 2020. We used our standard induction protocol, which includes thymoglobulin and steroids. At the time of transplant, he had proteinuria about 1.5 grams. That after transplant went down to 0.2 grams, but within a month had started to creep up and was up to 0.4. His creatinine, which had nodded at 1.5 after transplant, a month later was up to 2.4. And a month after the transplant, we did a kidney transplant biopsy, which showed that the C3G had recurred. At that time, his immunosuppression was increased, his myfortic was increased, prednisone was increased, losartan was added, aldactone was added, mostly to help with the proteinuria. When we tried to ask for anti-C5 post-transplant, it was initially denied. And so the patient continued with the baseline immunosuppression with slightly elevated doses. His creatinine kind of stabilized in the 1.4 to 1.7 range. Proteinuria stayed okay until 2024, which was last year when his creatinine started to increase and his proteinuria went up to 2 grams. We ultimately appealed, got ECU on board, Jardiance was started. And what happened then, of course, the newer therapies got approved earlier this year. And so when we wanted to initiate him on iptacopan, initially it was denied by insurance saying, well, the patient is non-compliant with losartan, so we need to actually get him back on that first, get him optimized on that. Before they would. Obviously, that did not make sense, and I think we do want to talk about that aspect. Carla did mention that in her talk already, that, while these drugs are important and they need to be continued, they're not targeted therapy. We were able to get him able to get him on IPTA, and so he's now been on iptacopan for about a month and a half. And I'll show you what the data is. But obviously, I think we know the answer, but I kind of still want to discuss it, that what if his proteinuria, if we had gotten him back on losartan more regularly, and he was on a maximum dose, and his proteinuria did get down below, say, 0.5, what would you do? And I think that was the question that was being asked earlier, is that, would you consider anti-complement therapy in this patient? And, I'll open it up to anybody, just whoever wants to start out. David, you want to start? I'll just go in order, maybe.
Okay. Remind me how long it was between the first biopsy and this worsening of the proteinuria?
So the first biopsy he had was a month after transplant in June of 2020, and now he's 5 years since transplant, that his proteinuria has worsened, and this is kind of where he is 5 years after.
And that was on eculizumab therapy, was
exactly. He had been on ECU for about a year before this happened.
So, it's quite a long time he's been on treatment. So I would probably have re-biopsied him just to see what was happening. But then that's me. I like to biopsy patients because that does seem a long time. So presuming we biopsy and we do see a glomerulonephritis on there rather than just C3, if the proteinuria improves, would I still consider anti-complement therapy? Well, if you've got glomerulonephritis, not all proteinuria reduction is the same. ACE inhibitors will not treat the target of disease, while complement inhibition targets what's causing disease. So I think they do different things. And if you see a glomerulonephritis, I would still give them an anti-complement therapy if there's a glomerulonephritis, even if the proteinuria has come down. Hematuria, again, it speaks of a glomerulonephritis, and I'd like to see it go down. But
yeah, and he's had hematuria ever since. Yeah. That never went away despite the increase in immunosuppression, despite the use of ECU. His hematuria has persisted. So I think to recap, what you're saying is that repeat biopsy, if you see a lot of acute inflammation, you would do a targeted therapy, versus if you saw scarring and we think the proteinuria is coming from scarring, you would not go for targeted.
Yeah, if all you see is C3 with no inflammation, right. I think it's difficult to treat, because we all see people with C3 in the kidney and you watch and nothing happens over the years. So I think if it's just C3, I would sit tight. If the C3 with any sort of inflammation, and I'd have a low threshold for that, then I would try to get them on a complement inhibitor. Threshold, I wouldn't have any in a transplant. If I saw inflammation and recurrence, I'd treat. Okay. Because I don't think all proteinuria reduction is the same.
I generally agree. Can I ask one question? Do you think there is any role for like biomarkers, just like C5b9?
Not well. I mean, I think the role for biomarkers is in the field of research at the moment, because anything I am not aware of any biomarker that will predict what we do here. I think, as with atypical HUS, once we had a drug that worked, then we could use some of the biomarkers to see who it wouldn't work on. Unfortunately, in HUS, it's still all genetic biomarkers that will predict who won't respond. But at the moment, no, I don't think there's good evidence that anything that we see will alter what we do. But I do think in 10 years' time, that the answer to that question will be different.
Any other thoughts? Or different thoughts?
I agree. I would rebiopsy definitely and go with the potential lift. I might send it to Iowa and measure the C5b9, and if it's elevated, even without clear evidence, I might use this information to convince the insurance company that I need this drug, because that's the reality. Sometimes you got declined. I can imagine very easily in this situation there is like 300 milligram protein, and the insurance company said, "Oh my gosh, that's nothing. I'm not going to support you. I'm not going to give you the drug, even if it's the clear evidence is there."
Yep. Right.
And just to come back to the point of the role of supportive therapy and targeted therapy, I think there will be a paradigm change where we're not waiting. Hopefully, there'll be a paradigm change where we're not waiting for someone to fail supportive therapy or have an endpoint beyond supportive therapy. I think there's a role for simultaneous rather than sequential.
Absolutely. Right. So the patient is actually scheduled for a biopsy, but he was started on iptacopan a couple of months ago. Like I said, his proteinuria came down from 2 grams to 0.2 in about a month and a half. His C3 went up nicely. His nephritic factor, which was positive earlier before transplant some years ago, is actually negative. And we actually did some of the testing that Miklos was asking, and everything is normal from a complement standpoint. And I think this is kind of why I was asking Brad earlier in terms of these fluctuations in nephritic factors that you see, whether that changes your mind and how you handle these patients or not. And do we have a good understanding of, what goes up, what goes down? He's been on immunosuppression for so long. Could that have contributed to this? Any thoughts? And I know you kind of talked about it, but any additional thoughts on this? Anything? Okay. Anything if you want to add? John, you wanted to say something?
So I mean, we're still waiting for another biopsy, right? And your creatinine's worsening. So
exactly. So these labs came back this morning.
We don't fully know what
I updated my slides this morning because he's scheduled for a biopsy, and we were not expecting to see this creatinine go up. Right. Obviously, he's a transplant patient, and it's been very unusual to see why his creatinine's going up. So he's actually, the order's in to get him on for a biopsy.
And we know that complement antagonism can have advantages in antibody-mediated rejection and other
Exactly. That is what my concern is, that obviously this could be rejection, but why now? I mean, is this just coincidence? Because this kid has been stable for 5 years, no change in immunosuppression, his tacro levels are stable, he's very compliant with his medication. So what just happened acutely in the last month that his creatinine is going up? This has perplexed me. I'm not sure. Nothing. I just actually talked to his mom this morning before, I needed to know the most updated information before I came here, but nothing. He did. I couldn't overlap the two. I did not want to overlap the two.
Yeah, you didn't want to, but could you have stopped the enclosure do different things? I mean, enclosure would not work C3G, but you have stopped it.
No. His heme parameters are completely normal. And he never had any heme parameters either.
Did you say that you had added an SGLT2 inhibitor? There was a couple
That
of
was a
different...
long time ago, not recently.
So nothing is
He's
new.
been like everything, the background therapy hasn't been changed. The only thing was done was his ECU was stopped, and then we started the IPTA.
DSA.
Yeah. You'll see my text that was ordered this morning because these labs came back today.
Right.
So DSA, CMV, BK, Allosure has been ordered and he's scheduled for a biopsy.
The background therapy, does it include the renin blockade things?
Yes, it does.
And is his blood pressure...
Blood pressure.
Occasionally what happens with when the iptacopan kicks in, this has been my experience, when it kicks in, you do get better inflammation on the biopsy, and patients do sometimes get better blood pressures, and then you're over-treating their blood pressure.
His pressures, in fact, when I spoke to his mom this morning, they've been running in the 130s to 135. To tell you the truth, nothing has drastically changed. I did wonder about it, that is he running lower blood pressures, and could that be the case? In fact, he went from 1.7 to 2.2, and we were thinking that's what happened. We asked him hydrate because sometimes he doesn't drink enough water. We see that in transplant patients, and everything's been fine, and then now it's further up. So this is making me quite a bit nervous, obviously. But I just wanted to see if, with your use of iptacopan or anything else, would there be a concern? I think there was some questions. Yes.
Yeah, I think these are transplant patients. They come very worried about the C3. The family is worried about the C3. The coordinator is worried about C3. But we tend to forget that they're transplant patients.
Of course. So the rejection workup is totally ongoing.
Not only rejection, we had a patient exactly like this, still not have urine leak.
Oh, well, so he's 5. He's
5 days.
He's 5. Yeah. He's 5 years out. Yeah.
But it was
of course.
Shooting creatinine.
Right.
And we're giving everything we have for the HUS, but actually she
forgot about the other things that are. I know.
Like 5 days after transplant, that can happen.
There is never surgery complication.
It took us another 5 days to convince the surgeon that.
Too many transplant nephrologists in the crowd right now. We can start. No, he's on azathioprine because he had GI issues with MMF, so he's on AZA. Again, stable dose of AZA. Yeah, I knew you would like that. All right. So, yes, please.
Maybe I missed something. So cheap. He came in for transplant. He said some of the assay that was fine. Now you mentioned that one biopsy was done post-transplant. And you also mentioned he was on 1 year of evolution. And does it include the post-transplant period, or that was before the transplant?
He was actually both times. Before the transplant, also he was tried on ECU, and then he progressed to end-stage kidney after 9 years. And then post-transplant last year, when his proteinuria was worsening, we got him back on ECU as well. So he's been on ECU both pre and post for a period of time.
But the resumption of eculizumab after transplant was a few years after the transplant.
Yes.
So the first biopsy that was done a month post-transplant, what did it show?
It was a C3G in the biopsy a month after transplant. Both C3 deposits, C3 and immunofluorescence and deposits.
And there was a lot of C3.
There was, yes.
So that brings me to another question. So if we do protocol biopsy for see when they recur.
Yeah.
I'm just going back to the point of when person asked about, okay, it will recur.
Yeah.
We know that most of the time recurs are efficient. They keep recurring, but I don't have to do anything. It doesn't have any proteinuria. I don't have to do anything at all for this C3 32 recurrence. So what my point is that we do protocol biopsies. So if we see C3 and if we think that most of the C3 that recurs are going to be bad if we don't treat it. And that is most centers that should see. We might have some few cases that don't have to do anything. But for majority of patients, when they recur, if we don't treat, they're going to continue. So if we are aware of biopsy that shows C3, at that point, at that one point, would you have started feedback on complementing?
We wanted to because he was, like I said, his creatinine was up and he was more proteinuria. So we wanted to. That's when we actually asked for eculizumab because we didn't have it.
Was at that 1 month?
Yes, and it was denied at the time, and we kind of kept him on the supportive therapy. And he kind of stayed stable for 4 years on that supportive therapy. But then last year, when he worsened further, we put him on ECU. So yes, I think if he had gotten more aggressive and had asked for ECU, we could have started him.
Would you have done a biopsy at that time when things were stable and then get worse? Why did we not do a biopsy then?
We could have done a biopsy at the time, but frankly, we figured we knew what the process was, and I don't know what would have added on to that. I mean, I guess there is no right or wrong answer, but we could have done a biopsy. Obviously, it's invasive. He's a young kid. So we could have, but my thought process was that this is an recurrence. I kind of knew this was coming. Frankly, I was not surprised when this happened. It's just that the timing, whether it's going to happen in 3 years or 4 years. So we did a biopsy, we just kind of treated.
It's also interesting the time course too. So if he has been without any complement therapy for those 3 to 4 years period of time, and you quote unquote stable. So during that period of time, if we have done a biopsy every year, will we see that there's a progression that is not manifested by proteinuria?
I think it's hard to say that in transplant patients when they're on immunosuppression because whether you would actually see that much inflammation when they're on prednisone and mycorrhizae, which again is not targeted, but it's kind of keeping that inflammation lower. We don't do protocol biopsies at our center, so we did not even consider biopsying him. We didn't have a therapy. What would we have done at the point? It didn't make sense. But if you're saying that his inflammation would have been worsening, I think that with the immunosuppression he was on, my suspicion would be low on that. And I think if it was worsening like that, I would have seen more of faster decline in the proteinuria than he did. That's kind of my assumption. But you guys have any thoughts on that? So I think we kind of discussed this a little bit when we were discussing the nephritic factors, and if there's anything to add, you can, but we talked about that the presence of specific nephritic factors at this point doesn't guide which therapy we're going to choose. I know Brad showed one case report of pegcetacoplan with C3 nephritic factor, but I don't think any of us are making a decision based on that. This question also came up that if this patient, suppose, was to get a transplant today, would you start him on anti-complement therapy at the time of transplant preemptively, knowing that he had a C5 nephritic factor going into transplant, getting a living kidney from a mother, which is, obviously every allograft is precious, but, any thoughts on what?
But didn't you say the nephritic factor is gone now, though?
Yeah, it is now, but I'm hypothetically saying that if he got a transplant today instead of in 2020, and he came into you today, he's, getting a living kidney and he has a nephritic factor, C3 is 30, and what would you do? Would you treat him preemptively?
My short answer would be yes. I know there is disagreement, but I think the right approach is just involving both the donor and the recipients for this discussion, right? So when you talk with them, let's say the mom is the direct donor, right? What I would suggest first is not the mom, just go with the pair exchange so we can get a younger donor. But I definitely discuss with the donor the recurrence rate because one of the worst things what you can, run into as a living transplant nephrologist, like the donor is super dissatisfied after we lost the kidney in 4 or 5 years. So after the discussion of the risk of infection, I would definitely ask, what do you guys think we should wait and do a biopsy, which is, let's say, 90% of the time is going to be positive within a month, or just go ahead and try to do with the risk of potential infection, but we're going to give you like a year antibiotics with the vaccination as well, and have a shared decision. But if they ask me what I would do if that would be my kid, I would definitely go with the preemptive.
And if you did start him preemptively, would you keep this patient on?
Forever?
Okay.
The answer is I don't know.
Okay.
I don't know yet.
All right, Brad.
I think an element to the case that you added, I think, probably would change my mind about essentially prophylactic treatment, and that's the fact that the C3 level is very low.
Yeah.
So the nephritic factor alone, I think I'd wrestle with it, but if it was the nephritic factor and there was clear evidence of dysregulated complement activity, I probably would. I think that's just waiting for a bad event to happen.
I know, exactly.
Personally.
That's kind of my line of thinking as well, to some extent. I just struggle with how long are we going to keep these patients and what happens long term. Yes, go ahead, Dave.
Is there any difference in your management, whether this is going to be dense deposit disease or C3GN only?
So I think dense deposit disease tends to have a more aggressive course, recurs sooner, tends to get to ESRD. I think 90 to 100% allografts, versus C3GN, we've always quoted 50 to 70%. But I think there was a paper recently that almost said that both of them were comparable. So, I mean, I still think dense deposit disease as a little bit worse, but I truly don't think that I'm thinking of them very differently, frankly, nowadays.
I just want to share one experience where the patient was recurrent dense deposit disease, and because of that, we kind of started preemptive FASN. But we do protocol biopsy. So 2 years later, or 1 year later, we did a biopsy, and the same pathologist who read the first one is telling me this is not dense deposit, and this is just not sausage shaped as it should be. And it just, there is some deposit, but does not look like dense deposit.
So not even C3G. This is like not.
No, C3G, but he's classifying it differently from dense deposit to C3G.
GN.
They did. And they pulled the previous slides and they said, I'm just saying there's some difficulty in classifying things. So we started preemptive based on the pathological review. But a year later, they refuted that.
Wow. Both C3GN and dense deposit, you would differentiate on EM anyways.
But does it actually matter whether you differentiate between dense deposit disease and C3? Because you're going to treat the same.
Let's be honest, we're living in a liquid field, okay? So every year we know more about it. So when this happened a year or 2 years ago, and we got the dense deposit, I'm like, we're nervous, right? So we started the iptacopan. Now, a year later, this patient has absolutely no problem, no proteinuria, no hematuria, with or without that. He does not even know that he's taking this medicine. Nobody will notice. And now the biopsy have magically changed.
Maybe not. I don't know if we can trust it.
So, I mean, coming back to this, I do, this case kind of tells us that you can get C3 deposition and it really doesn't affect the kidney. I mean, this person's had C3 there for 5 years and nothing's happened. So I think there's a difference between deposition and actually a glomerulonephritis. Because we could have been treating this patient with iptacopan for all that time, and he didn't need it. So I think you have to have a low threshold. I personally wouldn't do a protocol biopsy because you run into the same problems. Because if you do it and you see, you need to keep doing it. I would only do it if there was evidence of.
Yeah. I mean, that's kind of what we do at our center, anyways.
I mean, now there may be individual cases like your one where if you've got C3 recurrence twice and you've lost it quickly, you might want to think about that. I think there'll be cases where we presume with high certainty that that's the case, but based on this, he didn't have any complement turnover and he had C3 deposition. Why did that happen? So I think we're basing a lot on factors we can't actually interpret at the moment. So I think, it's like how many patients around the world are on eculizumab to prevent C3G recurrence and transplant. It just doesn't work. So I think we need to be careful about starting this when we cannot predict who will relapse.
Would you treat patients where the driver is known, like in this case, a nephritic factor, low C3, and you have evidence that there is activation versus you do not have any understanding of what's driving disease? Is there any difference in your mind about how you approach these patients?
I'm concerned worldwide that we are not detecting nephritic factors the same, and depending how we do it, we'll miss a lot. So I think the literature on that is poor. I think we need to get better at biomarkers and specifically nephritic factors. If you go to Iowa, that's probably great. But most places will do a test that will miss the vast majority of them. So I think the literature on that is pretty poor. And again, in 10 years' time, well, actually, nephritic factor analysis is incredibly difficult. You do need to purify IgG. That really cannot be run in a diagnostic lab. So unless we centralize around the world, we'll probably never get good assays. But I think I'll pass to Carla to discuss what she thinks about that.
Two comments. First one is that since, this is USTMA, so I'll bring up the plasmic score. I do think that eventually there would be a way of creating a way to look at the biomarkers to know what the score is going in, whether your patient has risk, because I agree 100%. You can't pay attention to one lab. You have to really stack the deck in favor or not in favor, because I'm not a transplant nephrologist, which makes it convenient that I don't happen to agree with prophylactic use of eculizumab or anything pretty much, but except for in these extreme cases. I do worry that we're going to do a lot of prophylaxis, and the problem is once you start, what is your indication to stop? And if you just stop it willy-nilly, why just start it in the first place? Mm-hmm. So I get worried about all of that, but I don't have an answer for it yet. Exactly. I'm hoping that we can develop a score that will actually allow us to figure out who's going to have risk, because, when the real world data is out there, it may not be as clean as what we're seeing in the trials, which is excellent, the safety, right? But if we learn from eculizumab, the real world data is different.
And with C3G, we do have time. It's not like atypical HOS where if you treat reactively, you run the risk of the kidney being shot. We're going to know, because C3G, there are very few cases where you lose a kidney from C3G in a matter of days. So you have that time to do the biopsy and to react.
But to my transplant friends, and you know this probably more than I do, they are using complement inhibition in these xenotransplants, right? So maybe it does make sense to use complement inhibition when you put a new kidney in. I would separate that from you're doing it for the C3G reason, though, I guess is where I'm going with it. Because there are plenty of these patients that don't recur. Not your lady who lost two. But there are plenty that don't recur. So how are you going to scientifically sort that out? And again, I come back to, when are you going to stop it? And the first time you have a patient die on you, which we've all experienced, right? The first time you have a patient die on you when you weren't sure of the reason why you were in the situation you're in, it can make a mark on you.
Yeah, but you are biased, right? Because the patient who dies on you, you saw the patient, but you don't see those patients who die on dialysis because we never transplant them. So yeah, I understand. But when you have two kidneys, lost, and you run out of the donors because sensitized and run out of the landing site from the surgeons, and you send back to dialysis, that patient is not going to die on you, but still going to die.
And again, I think we already agreed that your two loss is completely a different patient, 100%. Great.
Yeah,
but even if you do, they didn't lose their kidney in a matter of days. How quickly did they lose it? That woman.
No, but
how you didn't need to start immediately. You could have reacted, treated. Accusing Carla of not wanting to wanting somebody to die in dialysis, that's not it. If you transplant them and it comes back, you have that time to react. So yes, I think if you've got somebody that relapses quickly and does it again, you may want to do that, but they will be the odd cases. And I don't actually think there's much evidence that giving complement inhibition to people that don't have any complement defect in transplant actually works either. I mean, you run into the same issue you have. Question is like, does the Glomcom is putting together like a real life data kind of stuff, and you can have like a prediction score? That's not the plan.
It would be nice. It would be nice if we. And I come from a biomarker lab. I mean, I wish we were better at it. We're not better at it. We're just not better at it. But when we begin collecting more data and understanding, I think it is possible that you could come up with a score. And I'll give you a rule of thumb. We feel like if the example I offered earlier today, if we look at 8 biomarkers and 3 of them are off in the wrong direction, they're suggesting hyperactivity of the complement system, that's the patient that may actually recur. But going into transplant and having an isolated low C3 or an isolated, I look at low-grade nephritic factors like ANAs. I mean, you guys know this as nephrologists or as internists. ANAs are positive in everybody, right? Low-level nephritic factor by itself, I honestly don't think means a thing to you. So I like the idea of a score. I don't have the answer for it yet, but I like the idea of a score that might actually weight the evidence towards what the risk for recurrence is. But again, I'm going to be in the camp, more or less what David has just said too. I'm going to be in the camp. I'm not going to be a big fan of prophylactic because I don't know what the stopping point is. Unless, like I said, you're going to do prophylactic because you think it helps with, the inflammation related to the transplant.
Do you know where is the stopping point? Do you know where is the stopping point if it's not prophylactic? Like, if it's not, you are not giving the medication prophylactically. You start when you have the recurrence. When is the stopping point then?
Because we started it for a reason, so the stopping point was that reason went away. And you could argue, is it histology alone? So if you rebiopsy and the histology is melding away, that's my stopping point. Or if it's the UPC went to 3 grams and it went away. And again, I'm not saying you would stop. I'm saying it's like the eculizumab era, right? We finally discovered what we could stop and when we could stop after we gained more information. You probably don't leave your patients on eculizumab as long as you used to.
So there's a question from the virtual audience. David, this is asked for you. It's being asked that for the light microscopy feature to suggest activity, would mesangial expansion or hypercellularity convey a different thought process on what's going on to entercapillary hypercellularity? Do you see any differences in that kind of?
Our pathology friends will answer that the best, but I'll talk because I got there first. What I'm always told is that the intracapillary hypercellularity is the more melt away. It's the fastest responder to a targeted therapeutic. But David.
Yes, I agree with that. But actually, if I'm seeing any inflammation, I'm wanting to treat. If the issue is UCC3 with nothing else, I'm not going to do anything. If the issue is I'm going to have an incredibly low threshold for starting, and that is if the pathologist telling me there's any inflammation in there. I think what Carla said was right. I think I'm answering a slightly different question to that, in that I don't actually know, because we're changing the natural history of disease with these alternate pathway inhibitors, what's going to happen depending on the inflammation. But I think if you get C3 deposition with evidence of inflammation with nothing else, then that's when I'm good to start. So I'm not going to differentiate. I'm just looking for some evidence that there's a glomerulonephritis going on.
And another question from the virtual audience, and I think this is an extrapolation from the AHAS data, and I think I know my answer, but I'm very curious to hear. The question is, knowing that calcineurin inhibitors can cause a problem. I know, Carla, you mentioned the study from Christoph Licht in terms of affecting factor H function. Is there any reason to think that CNI should be avoided in C3G patients after a transplant?
No.
Okay.
No, and in fact, I think if you get acute rejection from avoidance, you could potentially provoke
that exactly is my
complement-mediated
concern too.
disease.
Yeah, and this is again, we definitely don't know an answer. I don't know. We are talking about the fact that you don't want to prevent, and I agree. I feel uncomfortable about who you would start prophylactic therapy on, but if you waited and you treated these recurrences, is there any concern that when there is inflammation and there is recurrence, you're causing some kind of injury and scarring that is long-term affecting the life of the allograft or the kidney? And I know there is no balance between, you start early and then when do you stop? So we don't know the long-term outcomes of those, where you would have started after something recurred and then stopped and recurred and stopped versus you just prevent the recurrence. Any theoretical thoughts on that?
Very theoretical. I mean, I would like it, and I know this is an oversimplification, but that would be like starting anti-BK therapy because you're worried the patient's going to get BK at some point, or starting a therapeutic just because things do happen to a transplant. So you have to sort through what's the risk benefit for you. And again, I'm not a transplant nephrologist, so you guys get to decide. But I mean, I think you just have to understand what your target is and understand what your goal is and understand what your risk is, I think. And I agree with you 100%. You've got to chat with the family. You've got to do a lot of chatting.
Yeah. Go ahead.
So I know we're talking about C3 and it's have high risk of recurrence, but there is other glomerular diseases we see as well. If you are from a center like does protocol biopsies, recurrent IgA is amazing.
Yep.
I mean, we just don't know about it because not everybody does, and they don't have proteinuria, they don't have hematuria, and we follow them. 10-year protocol biopsy, recurrent IgA.
Well, we'll be having those conversations now because we never had therapies for glomerular diseases. Now that we have therapies, we'll be having conversations with IgA nephropathy.
Recurrent membranous
yes.
with PLA2R positive in the biopsy, but not in the blood. So it is mediated, autoimmune kind of mediated, but no proteinuria or proteinuria 500 milligrams. Am I going to subject this person to? I think in certain cases it would be best to do close follow-up.
Yeah, I very personally struggle with the idea that, as nephrologist, and I'm not advocating one way or the other. I don't know the answer, and I'm not in one pool or the other. I think I'm very much in agreement with what Carla has said is more personalized therapy, meaning understanding what the risk of each individual patient of recurrence is, and maybe in specific subsets, you may need it preemptively in transplant patients. But I think if we could somehow do that risk stratification. But one thing I want to put out there, which kind of bothers me, is that if you think about the oncology world, they never give up on their patients. I know we've been sarcastic about, they'll treat the dead patients and they give them chemotherapy. Mm-hmm. And as nephrologists, we've kind of accepted the status quo that it's okay for a patient to be CKD. It's okay so what if it's a GFR of 18 or 20, we have dialysis. I feel like now that we have therapies, the mindset has to change from preventing CKD to happen completely. I'm not saying that's going to happen by doing preemptive therapy, but I do think that, when we start doing these protocol biopsies and we start identifying patients early, we have to think about earlier initiation. Not saying that what that earlier is, I don't know, but I do think that we have to get away from that CKD is okay in our patients. So that's just my philosophy for the day.
and as you said, registering the data so that we can follow it, and know exactly what's happening with the patients instead of using anecdotes, because we all use anecdotes, but that's not helpful to us, right? I mean, we need actual real collections of data to understand what's happening. If you delay, All
right, we'll move on to our second case. That's Purva's case from her practice.
All right, I'll go fast. So this is a 53-year-old male who presented to the hospital in September of 2024 with acute kidney injury, hematuria, and 12 grams of proteinuria. So the admission creatinine was 10, and he was initiated on dialysis for hyperkalemia and metabolic acidosis. So this guy's had very poor follow-up. And last creatinine 3 years ago was 1.5. There was no follow-up in between. His serologic workup showed hepatitis B surface antigen positive, and anti-HBC was also positive. So he gets a kidney biopsy that shows C3 dominant glomerulopathy with an MPGN pattern of injury with chronic active crescentic features and acute tubular injury. IF shows diffuse linear reactivity for albumin and IgG. C3 is 3+ in the mesangium, capillary loops, and glomeruli. Pronase digestion is also done, and antigen retrieval showed only trace IgG positivity. And lambda was slightly stronger compared to kappa in the protein reabsorption droplets and background of the tissue, but nowhere else. The electron microscopy showed subendothelial and intramembranous electron-dense deposits. And there was focal global, there was some scarring. Focal global glomerulosclerosis in 12% and segmental one in 0%, and there was 30 to 40% IFTA. So the patient at that time was started on steroids and mycophenolate and also weekly entecavir, which was dosed for his dialysis. He remained on dialysis. Genetic testing did not show any variants or nephritic factors. His complement testing showed, it's mentioned here, so pretty much okay. Additional testing showed an M spike of 0.9 grams per deciliter, which is high. Serum immunofixation showed IgG lambda. The kappa lambda ratio was running a little bit low. So remember, he's on dialysis, and you would expect a kappa lambda ratio to be high in dialysis patients or advanced chronic kidney disease, and his ratio was lower. And ultimately, we were able to convince the hematologist to do a bone marrow biopsy, and it showed 3% clonal plasma cells. So not meeting the criteria for multiple myeloma, but there is definitely presence of clonal plasma cells. So after being diagnosed with MGRS, so this is C3G with 3% clonality, he does receive clone-directed therapy with bortezomib, cyclophosphamide, and dexamethasone, and repeat bone marrow biopsy is done with undetectable plasma cells. So he got the therapy for a total of about 4 to 5 months, came off dialysis in about 2 months, but remains with a GFR of 18 to 20 ml per minute. There's no improvement in kidney function at 6 months, and now he's being worked up for a kidney transplant. All right, so my first question is, so we know that there's a very distinct role of monoclonal immunoglobulins as the etiology for C3G in older adults. So in those patients who have positive testing for monoclonal disease, should we do a full complement functional testing for genetic variants, nephritic factors, or should we just treat the myeloma or treat the MGRS? Or do we go, is there any utility in testing for everything?
I'm sure David and I are going to disagree on this one, but the problem is, at his age, I don't remember what the stats are, but a lot of people wandering around out there have some monoclonals. Lots of people wandering around out there. So I am not sure that it's only the monoclonal going on here, frankly. So I think you have to consider whether he needs a genetic workup going into transplant. I'm a little less... The advantage of doing the biomarkers is you would figure out whether he still has potentially systemic complement dysregulation, meaning if you had no pink boxes on that biomarker panel, it might satisfy you that, you know what, they are doing a good job getting rid of his monoclonal. Maybe he's not really dysregulating his complement system again. But I could be argued out of this.
To suggest we might disagree, I'm shocked. I completely agree. You've got somebody with hepatitis B and C, and you haven't told me if they've got a cryo. You haven't told me if they're controlled. Do we know that this monoclonal chemopathy is actually causative? Do we know this isn't just chronic infection depositing in the kidney? You haven't told me that.
Yeah, so hepatitis C was negative.
It was negative, and hepatitis B was?
Hepatitis B surface antigen was positive. His HPV DNA was positive.
So
but
what was positive? Sorry.
So he did have an infection, but that was controlled with entecavir, and his titers came down pretty nicely.
So we've got a chronic infection. Do we know it's due to that? Did he have cryos?
Yes, and they were negative. Yep.
He did have cryos, and they were negative. So, first of all, we would have worked him up that way. Why was he hit B positive? Has he got an echo? Do we know he doesn't have endocarditis? Was he an injecting drug abuser? Why? So essentially, I would actually have taken it one step before we do the biomarkers. I'd have wanted to kind of do a full screen.
So his UTOX was negative when he came in because his blood pressure was also very high. So there was a suspicion that he was doing something else. So on admission, his UTOX was negative.
And then presumably his echo was negative because you've then immunosuppressed him, so it would have got worse.
Right.
But I mean, if I was doing it actually before I would have done the biomarkers, I'd have done the kind of basics things. I agree with you completely that. I mean, he wasn't that old, was he?
53.
We start to get monoclonal bands. I'd come back to the biopsy to see exactly what it was. But, I mean, as to whether we would do it, personally, we would do it. However, it wouldn't change what you do.
But when you say that, older people have monoclonality, we're sort of going against the concept of the MGRS then. We have a C3 and we have a monoclonal protein. So I think we're sort of
what you've got is you've got a monoclonal band and you've got restriction in the biopsy, and I can't remember, but I presume they're the same. So I think you've actually got quite good evidence. I think Carla's point was a more general one, saying the older you get, the more likely you are to have a monoclonal band, which I agree with.
Monoclonals are going to be anti-complement. I mean,
Right.
they're going to be anti-something, but they're not necessarily.
Or even just depose it and activate complement.
I mean, and with this, actually, my answer is I test everybody. I want to know what's going on from my. But I'm asking you, if this was 70, would it change? Would you test? It would not.
Well, I think, these cases come up, they're often framed as monoclonal gammopathy as the cause of the C3G. And the vast majority of the literature is associative, right? And we don't know. Maybe if we treat everybody with C3G with bortezomib and cyclophosphamide, and daratumumab, maybe we will eliminate the nephritic factor we didn't find or whatever the other cause is, right? So for me, at least, I would do the full workup. And I always look at monoclonal proteins as the diagnosis of exclusion. And so it's there. And if I find no other cause, or if it's a complement-mediated TMA and I find no other cause, then maybe that's where I hang my hat, but I still don't have causative proof.
Okay, I'll come back to you with that. So we've got a monoclonal band. It's restricted in the biopsy.
It's not clearly restricted. There was a slight predominance in protein resorption droplets, which that's pretty soft.
Yeah, I can't actually remember what
on the biopsy, no.
If there was a restriction,
in the serum, yes.
And there's a
serum.
In the serum, not the biopsy.
You had a slight predominance.
What was
the biopsy?
Was that kappa?
The lambda. There was a lambda.
And so there was a lambda, and did we get slightly? Lambda was slightly stronger compared. So we've got a lambda. It's slightly stronger.
In the resorption droplets, which we know has a monoclonal gammopathy. There's going to be more filtered. It's going to be in the.
Right. I wouldn't make much of that. I think
it's not so much this case, but if you've got evidence of a monoclonal band, if you do that, and you find a nephritic factor, then what does that tell us? Do we then need to type the nephritic factor to see if it's the same as the lambda? Because essentially, if you've got a monoclonal band, it could just be depositing and activating complement that way, or it could be acting as a nephritic factor, but actually doesn't matter. Well, I mean,
but you may be treating a lot of things by treating the monoclonal protein, and so I don't know that it matters, right? But here you've got protein resorption droplets that have a little more lambda. We know there's a lambda monoclonal gammopathy. This is not a biopsy that's restricted for a light chain.
Very much more clear cut restricted, then you wouldn't test those patients?
Well, I think you can test from a scientific standpoint to try and better understand as we learn about this.
Well, I don't think currently any complement biomarker alters what we do for C3G. The only thing that would is if we were, and again, what we're really discussing is how good the evidence we think for a monoclonal driving this is, but no biomarker itself will alter what we do. All it does is allow us to be more confident in our diagnosis. But if you've got, say, a factor H autoantibody and a monoclonal band, you don't know, are they completely separate? Is one driving it? Is the other driving it? And in that case, you need to make a call. So I think that's a different.
We had that exact same case where we had a patient with monoclonal gammopathy. She was C3 nephritic factor positive and factor autoantibody positive. This is the patient I was talking about. Got a transplant, was not treated for the monoclonal gammopathy because this was several years ago. We got a lot of pushback from hematology. Gets a kidney, recurs with C3 gene in the kidney. Then when she was treated for the monoclonal gammopathy, both her nephritic factor and autoantibody went away. Then she had recurrence and they both came back. So had a very beautiful way of showing that they were clearly associated with the monoclonal protein without us testing if they rise.
My sense is if you believe nephritic factors are pathogenic and
Yeah.
you have a clearly detectable complement dysregulation in intense nephritic factors, and MMF and prednisone is not going to be real strong in that regard, and rituximab doesn't work, I bet a lot of those patients might actually get better with more targeted immune suppression,
So
which is
my
what you're
question
asking.
is, if you had monoclonal gammopathy, you tested them for nephritic factors, you tested them for biomarkers. Your nephritic factor is positive, your biomarker is positive, but they have the monoclonal protein. Wouldn't you still want to first target the monoclonal protein rather than going for anti-complement therapy anyway? So I think it kind of helps you get the whole picture in a way, but it doesn't change what we would do.
No, and you certainly wouldn't want to hold this patient up from transplant because, for instance, there'll be places in the world that don't have the biomarkers available to them. So you need to move this patient along the road. You can't stop them because you can't get access to them. So they don't affect what you're going to do except for make your understanding of the case a little bit clearer, perhaps.
I'm sorry. Let me look at the case from the beginning, okay? So, in my recollection, when I was a fellow, we did not have C3G. That was called post-infectious GN that did not resolve, or remnants of a previous post-GN. This person had an infection, technically could have activated the complement system. He had, I'm not sure you mentioned the intensity of the deposits because it has to be like 3+ or more.
Yeah.
So, I mean, this was not mentioned. Again, we are trying to focus on the C3, but I'm just trying to put it. The fact that this person had a Hep B to start with, an MPGN pattern, and normal complement. I understand there was a little bit of lambda, a little bit of C3, but I feel this is infectious mediated GN. I'm not sure. Okay.
Right. So
and now we did treat. There was the monoclonal gammopathy. He recovered, and the Hep B, and he recovered kidney function. I'm not sure if he recovered other parameters, like as far as proteinuria and hematuria or not. But he has viable kidney still. Do you think that doing another biopsy now can help you redefine the disease?
Yeah. So interestingly, he didn't have any IgG positivity, and he has C3 was 3+. So which made us think of. So you're absolutely right. I think that was our first thought, whether he has infection associated GN. So, but there was no IgG, and that's why actually we did the pronase digestion and antigen retrieval. Also showed very trace IgG positivity. So, and C3 was trace. No, I'm sorry, C3 was 3+. So which made us think that this is more sort of an alternative complement pathway dysregulation rather than, sort of an infection-associated disease. So, which is, and I mean, repeat biopsies is always a good idea, I think, in my opinion. Yeah. So,
But I think it's a good point, right? Because the goal is always to treat what's causing the disease, and even targeted complement therapies don't treat the cause of the disease, right? In many of these instances. Now, maybe, if a genetic variant that's activating something of this sort, it'd be a little more direct to it. But from an autoimmune standpoint, we would still love a cure, right?
Mm-hmm.
And so, you talk to our pathology colleagues and you get some of these C3 patterns in the mesangium, and there's a history of sort of infection in the background, and it's always like, well, is this just sort of a atypical, for lack of a better word, infection-related GN or not? And so, we do the best to try and sort that out as time goes by, but it's not always clear-cut. And, Got an
I
active
mean, would you
viral
expect
process
IgG
here.
though? You would expect a decent amount of IgG if
Not
this
always.
was
I mean, there's
infection.
the textbook descriptions of infection-related GNs, but we see a lot of folks that, as time goes by, clearly would not fit C3G, but in the moment, right, there is a C3 dominant glomerulonephritis,
Right.
and they're hospitalized. There was other things going on that really just sort of brings up these and I hate the word, but sort of an atypical infection-related pattern.
We have a question from the virtual audience asking that if there is any assay or variable that helps you test whether that monoclonal protein is acting like a nephritic factor. Brad, I'm looking at.
Yeah, I think that's very hard. Part of that is like you have to have for many nephritic factor assays, you need a fully assembled IgG protein, and so if it's only a kappa or lambda, if the light chain itself is acting in that way, you may not be able to detect it. Depending on the assay, there may be assays that, like the immunofixation electrophoresis, I think you would get functional evidence of dysregulation with that. Yeah.
And the other thing you can do is if you find it. The other thing you can do is if you find the antibody, then you can type it. So it's either kappa or lambda, but even then you're skewing the fact, but you can never say definitively that a monoclonal band is driving it, but you can say the monoclonal band is the same as the autoantibody.
The next question is a little controversial, and I know Carla, I'm going to talk about the paper, but I kind of want to bring that up.
Right. So I think what's the role of complement inhibitors in a patient like this? So this patient is a little different because he had no follow-up in between. So I don't think this was all acute. I think this was probably going on for some time, and he had 40% IFTA. But if this was somebody who was sort of rapidly worsening or had active disease, would you use complement inhibitors as a bridge to treating for monoclonal MGRS, or would you use complement inhibitors as rescue therapy in someone like this who got treated for MGRS, went into remission as far as MGRS is concerned, but still remains with disease? I'm assuming we're going to prove it with a biopsy as well, sort of repeat biopsy after he's been treated. But what's the role of sort of targeted therapy in a patient like this?
I can give you my opinion, but so you're telling me that, for instance, you feel very strongly that this monoclonal is causing it, but you're still wanting to know whether a complement inhibition is useful. I wouldn't have, particularly if we have a kidney that's in danger, we've got a rapidly progressive, not RPGN, but we've got someone losing kidney function and they're sort of piddling away about getting rid of the monoclonal. I wouldn't have any problem at all double treating this patient, go for the clone and protect the kidney with complement inhibition. But that's just my opinion because I've never seen any data on that except for Sophie Chauvet's group did eculizumab. Did they ever publish that?
One case.
Yeah, Frank Bordeaux's group. Anyway.
What we really need is a clinical trial of this. I happen to think it'll work. It's actually there are lots of patients out there. I think it's liable to stop. Many of these will activate complement. It's liable to work. We need to show it works. It comes down to a bit like IgA. IgA, we're not going to use C3, in fact, alternate pathway inhibition for life. We're going to try and get rid of the cause. So to me, I think it would work. I think it would work in the short term. I'd want to see maybe a trial, but ultimately you'd want something where you were trying to get rid of the clone. So, to me, I'd like to see the same sort of trial we saw in an IgA, because there we're going to end up using complement inhibition in a very short term until we get rid of the cause.
So, David, would you use them simultaneously? Because this is a lot of immunosuppression, we have to, remind ourselves.
Well, I mean, is it a transplant? Have we
No, this is not transplant. Going into transplant.
I mean, so if he's going into transplant, if he's on dialysis, then I don't need to. I would just get rid of the clone.
If this was a progressive and didn't go on.
Well, I mean, in the evidence of sorry, jet lag's definitely kicking in now. In the absence of any evidence, I think there's a good rationale that alternate pathway inhibition in the short term till you got rid of it might work, but the therapy is quite quick, and if you get it in quickly, I mean, is it going to make much difference? I can see it having an effect, and certainly in atypical HUS, the incidence of monoclonal bands is higher than the general population age match, and they do seem to respond to complement inhibition. So I do think that many of them will be complement dependent, but we need a trial. But is anybody going to do the trial? Because ultimately the therapy will be getting rid of the clone.
Yeah, and since you brought up atypical HUS, so for me, the analogous situation would be the patient with factor H autoantibody. You're very frequently going to put them on eculizumab to stabilize the kidney while you're attacking the B cells so that you can get rid of the factor H autoantibody.
Of course, in the UK, we don't do that. We just give eculizumab.
Can you say that loudly?
In the UK, we do not get rid of factor H autoantibodies by B cell depletion. Well, they actually do, yeah. No. I mean, yeah. Well, they do. I mean, we followed them up, and some of them just disappear. So there's a lot of evidence out there saying if we give lots of immunosuppression, it gets better. But actually, we follow these up. And we've stopped patients because it's just got better on their own, because there has to be some sort of immune reset. Now, not everybody does, and that some patients will develop a GN because of the immune complex from that. And at that point, we would immunosuppress, but eculizumab's very good. So, I mean, not everybody immunosuppresses.
No, and that's exactly what I've seen. And the reason I wanted you to repeat this was because very recently we've had questions, particularly I was asked to give a talk in India where there is heavy, factor antibody. They have a whole protocol in pediatric patients with plasmapheresis and immunosuppression, and they didn't have the drug. I mean, we're digressing a little bit, but in our experience, I have not seen a lot of autoantibodies go away, and particularly because I deal with the transplant population, and you're thinking of the logistics of getting somebody who's on dialysis, pre-transplant, on all this immunosuppression to get rid of the factor autoantibody. But what I have seen is that we will treat these patients with ECU, and when I repeat them a few years later, those have gone away and we've stopped therapy. So that's been my approach, but I know this question comes up because a lot of institutions do want to avoid anti-C5 for cost and other reasons, and the whole immunosuppression with factor autoantibody comes up over and over again. So so we are, I don't know, depending on how much energy you guys have for one more case, or we can completely stop it here. I'm gonna just take a show of hands. Stop. Okay, we can go ahead and stop and give everybody, take it easy. Is that good?
Yeah,
all right, sounds good then. Very good. Well, thank you, everybody. This was fantastic. Wonderful discussion. It was amazing. Thank you, everyone. Yes, absolutely. No, I loved it. We want people to talk. I mean, the discussion is what keeps them.
This is like chronic HPV.
Yeah.
It's not acute HPV.
No. That's what we want.
No, this is great.
We're talking. Otherwise, there is no fun to this. The workshop has to be.
Literature say in the case of infection and find C3, rebiopsy after phase.
Yeah. But that is totally there. Yeah, I think that is a standard.
That's like
that is. Yeah, no, yes, no, that is standard. Whether you biopsy at 8 weeks or 10, I think that is very standard for sure. Yes. Alex, what do we need to do? Yeah, thank you for coming, honey. Yeah.